Hello everyone, today we'll discuss about bladder cancers. It is the fifth most common adult malignant neoplasm in the US. Men have nearly 3 times more incidence than women and is related to impaired bladder emptying with age. Most frequently arises in patients with more than 70 years old. The cardinal sign is painless gross hematuria. Some even have microscopic hematuria. A single episode of gross hematuria, especially in smokers, carries significant cancer risk and warrants a full workup. Irritative symptoms like frequency, urgency, dysuria are also present. Etiological factors of bladder cancer. Chemical and occupational smoking has 2 to 5 times increased risk. Industrial solvents like arylamines, aniline dyes, aromatic hydrocarbons, occupations like tanner, rubber worker, painter, hairdresser. Chronic inflammation caused by indwelling catheters and bladder stones. Parasitic infection, Schistosomia hematobium causes bilharziosis, which causes squamous cell carcinoma of the bladder. Iatrogenic exposure to radiation, cyclophosphamide usage also provoke cancer. Genetic susceptibility is of the genes Na2, GST-M1 mutations. Pioglitazone is contraindicated in active or patients with history of bladder cancer. Bladder cancer occurs in 3 main pathological forms. The first is the urothelial carcinoma, which accounts to more than 90% of cases, and its main etiological cause is chemical exposures like smoking, aniline dyes, cyclophosphamides, and it originates from the basal cell layers of the variable epithelium. The second is the squamous cell carcinoma, which accounts to 1 to 7% of cases and is because of chronic irritation by schistosomiasis, chronic catheters, and stones. The mechanism is by the recurrent infections which lead to keratinizing squamous metaplasia. The third is the adenocarcinoma, which accounts to 1 to 2% and is because of the embryological remnants and arises from the persistence in the region of the urachus or the trigone. Non-invasive diagnostics and biomarkers. The first is the imaging. CT urogram, gold standard for upper tract evaluation. USG KUB. It identifies intraluminal growths, clots, and nodal status. Second is urine cytology. It is highly sensitive for high-grade tumors and CIS, carcinoma in situ, notoriously low sensitivity for low-grade disease. Third is the advanced biomarkers. FDA approved test for the NMP22, nuclear matrix protein, and FISH Eurovision. FISH Eurovision mechanism detects aneuploidy of chromosomes 3, 7, 17 and homozygous loss of 9p21. It offers 100% sensitivity and 100% negative predictive value in patients with negative cystoscopy. The invasive form of the investigation is cystoscopy and is known as the TURBT, transurethral resection of the bladder tumor. It is of both diagnostic and therapeutic importance. It has dual purpose. It provides pathological analysis and T-staging by identifying the presence or absence of muscle invasion, potentially therapeutic for non-invasive diseases. The muscle mandate. Sampling muscularis propria is absolutely required to rule out T2 disease. If a high-grade tumor is resected without muscle in the specimen, a repeat TURBT within 2 to 6 weeks is mandatory. Bimanual examination under anesthesia is performed post-resection. A palpable mass presents extravesical extension, T3. A fixed lesion suggests pelvic side wall invasion, T4. To enhance our detection, we can use advanced cystoscopy technologies. The white light, which provides the standard view, has diagnostic accuracy, relies heavily on operator experience. Flat carcinoma in situ lesions are easily missed. The blue light uses hexaaminolevulinate HAL illuminates at 360 to 450 nanometers, providing porphyrins in tumor cells to fluorescence red. The narrowband imaging uses blue 415 nanometers superficial and green 540 nanometers deep light strongly absorbed by hemoglobin. Vascular structure appear dark brown or green. Optical coherence tomography. Near infrared light is used in this, which has a wavelength of 890 to 1300 nanometers. Cross-sectional tissue microarchitecture can be noted. Confocal laser endomicroscopy. Fluorescence agent 488 nanometers low power laser is used. It provides real-time cellular imaging. Pathological staging of bladder cancer depends on the depth of invasion. TA, the non-invasive papillary carcinoma. TIS, the carcinoma in situ. T1, which invades the lamina propria. T2, which invades the muscularis propria. It has again T2A, in which inner half or superficial layer of the muscularis propria is involved. T2B, in which the outer half or deep half is involved. T3 invades perivesical tissue. T3A, there is microscopical invasion. T3B, there is macroscopical or extravesical mass. T4, it invades the adjacent structures. T4A, prostate, uterus, vagina are involved. T4B, pelvis or abdominal wall are involved. Coming to the lymph node stage. L1, single regional lymph node, hypogastric, obturator, external iliac, perivesical, presacral can be noted. The first node to drain is the obturator lymph node. N2, the multiple regional lymph nodes in true pelvis. N3, common iliac lymph nodes are noted. M0 is no distance metastasis. M1A is non-regional lymph node only. M1B is distance metastasis. The urothelial cancers can be divided into low grade or the high grade type. The low grade have a alternation in the chromosome 9, in which provides mutations on the FGFR3 and PI3K RAS gene. The mechanism, it acts by switching from 3B to 3C in the FGFR3 isoform and triggers oncogenesis. In the high grade, heavy mutations in the TP53 and RB occur, which lead to T1G3 variation, which has 80% recurrence and 50% progress within 3 years. They are further graded into well differentiated, moderately differentiated, and poorly differentiated. The important prognostic factor of bladder cancer is the depth of invasion. After cystoscopy and TURBT by cautery or the NTAG laser, the tumor stage is identified. Then it is further divided into non-muscle invasive bladder cancer and the muscle invasive bladder cancer. The non-muscle invasive bladder cancer involves the TA, TIS and T1 stages. They have to undergo observation and intravesical therapy using immunochemotherapy, and the muscle invasive forms undergo systemic chemotherapy, radical surgery and radiotherapy. American Urological Association non-muscle invasive bladder cancer risk stratification. The low risk, it includes low grade solitary TA grade tumor of less than or equal to 3 cm size. The papillary urothelial neoplasm of low malignant potential is also included in this. Intermediate risk, recurrence within 1 year of low grade TA tumor, solitary low grade TA tumor of more than 3 cm size, low grade TA multifocal, high grade TA of less than or equal to 3 cm, low grade T1. High risk, high grade T1, any recurrent high grade TA, high grade TA 3 cm or multifocal, carcinoma in situ, any BCG failure, any variant histology, any lymphovascular invasion, any high grade prostatic urethral involvement. 60 to 80% of NMIBC tumors recur, and up to 20% of high-grade tumors progress to muscle-invasive stages, mandating precise stratification for subsequent therapy. After performing TURBT, as per the risk stratification, either immediate chemotherapy or immunotherapy are administered. Immediate chemotherapy is given to low or intermediate risk within 24 hours. Mitomycin C or gemcitabine are administered. It reduces tumor risk by 30%. Immunotherapy, high risk or carcinoma in situ undergo this. BCG is given. It administered once every week for 6 weeks, and periodic maintenance is given for 1 to 3 years. The localized immunotherapy significantly decreases recurrence and progression. Novel agents for BCG unresponsive disease are the nadofaragene, firadenovac, adenovirus vector delivery human interferon alpha 2b cDNA. The other group is the Synergo or HIVEC. Hyperthermic intravesicular chemotherapy up to 42 degrees centigrade is given. Intravesical therapy toolkit. The standard kit contains mitomycin C. It is a standard intravesical chemo drug and can be delivered by electromotive device administration. Gemcitabine is an alternate to MMC and has a safer profile. BCG is the standard drug and is given for 6 weeks. It is used in immunotherapy. Invasive disease, the neoadjuvant surgery and adjuvant therapy are followed in combo. In the neoadjuvant therapy, the MVAC or the GC regimen is followed. The MVAC consists of the methotrexate, vinblastine, adriamycin and cisplatin. Or gemcitabine or cisplatin combo can be administered. The goal is to achieve pathological PTO at cystectomy. It is associated with significant improved overall survival. Then radical cystectomy is planned, and after which the adjuvant nivolumab is administered. And for patients with PT3-4 staging or PN plus who are eligible for and who have declined cisplatin, this is administered. In the surgery part, radical cystectomy with extended lymphadenectomy is performed. In male resection field, entire urinary bladder, perivesical fat, prostate, seminal vesicle and pelvic lymph nodes are removed. In females, urinary bladder, perivesical fat, uterus, cervix, fallopian tubes, anterior vagina and pelvic lymph nodes are removed. The critical role of extended pelvic lymph node dissection is removal of external or internal iliac, common iliac lymph nodes to aortic bifurcation and presacral nodes, and is directly associated with improved survival. Extremely high perioperative complication rate exists, more than 60% cases within 90 days. After cystectomy, the mechanisms for providing urinary diversion. Most commonly, ileal conduit is done, which is incontinent. The ileal segment is connected to a stoma or urostomy bag. It is the most common non-continent diversion. Ureters connect to an isolated ileal segment, and it is denoted as chimney, and drains continuously through a stoma into an external urostomy bag. Other method is to construct a new bladder, that is orthotopic neobladder, by using intestine, in which a studded pouch is formed by using the intestine, and the native urethra are connected to the reservoir. The patient voids by relaxing the pelvic floor and straining. There are other methods of formation of the neobladder also, but studded pouch is the most common one, and the decision depends on the renal functioning, liver functioning, prior pelvic radiation and patient manual dexterity preference. The metabolic cost of intestinal diversion. For the stomach, it causes hypochloremic, hypokalemic metabolic alkalosis. For jejunum, it causes hypochloremic, hyponatremic, hyperkalemic metabolic acidosis. For the colon, it leads to hyperchloremic metabolic acidosis with total body potassium loss. The long-term mechanical and metabolic risks noted are the vitamin B12 deficiency, bone demineralization, recurrent UTIs, increased risk of adenocarcinoma at the anastomotic site.
The tri-modality therapy of the bladder sparing route that is suitable for patients with no hydronephrosis, good bladder capacity, solitary tumor, no carcinoma in situ. The maximal target clearing surgery needs to be done. Concurrent chemoradiotherapy with cisplatin with or without 5-fluorouracil is available, along with radiation of 60 to 65 days. Then evaluation is done. Failure or leads to salvage cystectomy. The success, surveillance is done.
The trimodal bladder preservation strategies further have the split course therapy or the continuous course therapy, in which induction chemoradiation of 40 gyre is given. Mid-treatment endoscopic restaging is done. If there is no persistent invasive disease, consolidative chemoradiation of 60 to 64 gyre is done. If persistent invasive disease is present, immediate radical cystectomy is present. Continuous course chemotherapy, endoscopic restaging happens after 3 to 4 months after full course of continuous chemoradiation. Common agents like mitomycin with or without 5-fluorouracil are administered. Coming to the treatment for metastatic diseases, first the platinum eligibility criteria is checked for. The criteria includes renal function. The GFR should be more than 50 to 60 ml per minute. There should be the physical fitness as per the ECOG score of less than 2. There should be no peripheral neuropathy and no significant hearing loss, no heart failure of greater than class 3. If the eligible criteria is yes, then the patient is administered cisplatin or gemcitabine or the dose-dependent methotrexate, vinblastine, erythromycin and cisplatin for 4 to 6 cycles. This is followed by a maintenance dose of the evolumab. If the patient is platinum ineligible, the GFR is less than 30 ml per minute, then we check for the PD1 status. And if it is positive, we go for the itolizumab and pembrolizumab therapy. If PDL1 is negative, best supportive care or clinical trials are still undergoing. Targeted therapies. The target FGFR 2 or 3 alterations are given or treated by the erdafitinib. The Nectin-4, the therapy given is enfortumab vedotin. The target TROP2 is treated by sacituzumab govitecan. The standard chemotherapy agents used are the mitomycin B, gemcitabine. The immunotherapy or hyperthermic agents are used are the BCG and HIVEC. The novel or the newer group of drugs are the nadofaragine, firadenovec, epaxequan, nanoparticles and Panvac. Coming to the treatment surveillance, the non-muscular, in that the low risk undergoes cystoscopy at 3 months followed by 12 months annually till 5 years. In the intermediate risk, cystoscopy is done at 3 months followed by every 3 to 6 months for 2 years and then annually. In the high grade, cystoscopy plus cytology is done for 3 months followed by every 3 months for first 2 years. This is followed by 6 months for next 2 years and then annually for the next 2 years. And in case of post-cystectomy surveillance, lab examinations done are the renal function monitoring and B12 in cases of neobladder. This is done every 3 to 6 months for 2 years and followed by every 6 to 12 months. And imaging studies done are CT chest, abdomen or pelvis every 6 months for 2 years and then annually for 5 years. Thank you.